All right, for our next panel, I want to welcome our next speakers. Y'all met Jason Helgerson this morning with the Helgerson Group, and we're also adding Alex Kirkland with Coker. Alex Kirkland. Alex is an MBA and a senior vice president at Coker. He has more than 15 years of healthcare experience from a financial and operational background, focusing on physician compensation, reimbursement models, and population health. His primary focus with Coker is on physician alignment transactions, compensation trends, and payer reimbursement strategies. Notably, Alex helped develop a medical specialty organization framework to assist their membership in evaluating alternative payment models. We also have with us today Luis Argueso. He's a co-founder and partner at InHealth Advisors. Luis is with more than 15 years of experience in advisory and valuation services. Luis specializes in working with a wide range of provider organizations to develop effective value-based incentives. His work involves the development and administration of value-based enterprises and providing fair market value opinions. And so y'all have the clickers if you want to go to your slides. We'll start with Jason, sort of kick off with a question. I think you're going to give us a description of what you would view as an ideal corporate structure for a scalable value-based provider business and the type of things the company needs to get right to grow across state lines and be cost effective.
Sure. So it's a pleasure to be back and really appreciate the last couple of panels. Super interesting, very thought-provoking. And actually, what I'm going to talk to a bit here I think also is partly came out of a need to address a problem that was discussed at the last panel. There's a lot of discussion on that panel around this issue of Medicare risk adjustment and the fact that Medicare risk adjustment, particularly for complex populations, unless your total population is very large, that the risk adjustment methods actually not only disincentivize you to take on the most complex, whether that's duals or homebound or in certainly individuals that are in end-of-life situations or approaching end-of-life situations. If that group of patients is a decent size of a total pool and the rest of your membership is, say, let's call it traditional Medicare, it can be a very dangerous proposition to do particularly upside-downside risk contracts with sort of those two different populations. And what does that mean? It means that we're disincentivized from trying to focus value-based care on the highest cost, most at risk, most vulnerable individuals in our society. I mean, that's just wrong. I mean, we should be creating programs that overly incentivize us to focus on those individuals who frankly need the health system to work the best. And I think unfortunately, because of the importance of risk adjustment, we talked a lot about all the HCC coding efforts and such, but I still think it's just a challenge that hopefully some of the new methods, particularly in the concurrent DSNP methodology that was discussed briefly, can help. But I still think that's an area where we do need some policy change, and perhaps we'll see that out of CMMI in the not too distant future. But basically here, my job was to sort of talk about, and this is really a panel where we're focused on sort of entrepreneurial providers, which if you think about it in history, it's a relatively recent phenomenon in the sense of much of American healthcare traditionally provided on a sort of a regional or a very local basis. So providers providing services to the people in their immediate area. But as time has gone on, and particularly entrepreneurs seeing opportunities, seeing inefficiencies, and a lot of those entrepreneurs in turn backed by capital that up until I don't know how many years ago really wasn't necessarily available or certainly not focused in healthcare, which is private equity, investment capital, and also some venture funds as well, to really fund the development of these organizations. Some of those organizations are sort of like the de novo type organization where they are sort of created from scratch. They open up new clinical sites or create new providers through their own investment, hire their own staff. In other cases, it's they don't like to call it this anymore, roll-up strategy, where you're going out and actually acquiring provider groups in a variety of different markets, and then trying to organize those to achieve some synergies, try to get them to function more as a coherent sum that's greater than the parts. But one of the challenges is scale. And I think there's been quite a few examples of organizations that got started, particularly when there was a lot of venture funds flowing into the health tech sector. A lot of those organizations maybe had some early success, but really had a hard time scaling. Some of those organizations very value-based care focused. Lots of reasons for challenges around scale, but I think one of the challenges is just the corporate structure. And this sort of gets back to, you know, and I will defer to Ed here too to talk, because so much of this is also about the legal construct under which a value-based entity is created. And I think the creation of the value-based entity framework and some of the protections it gives around Stark and anti-kickback law was a major step forward for value-based care. It opened the door to potentially corporate structures that not only allow for collaboration and focus on outcomes and performance, but also makes it easier, frankly, to scale. And so just the two slides that I have here is to show a corporate structure in which you have a parent that establishes an MSO, a management services organization, that also happens to be a value-based enterprise, and that underneath that organization is owner of multiple assets, or in some cases you could also include not assets that are owned, but that are partner organizations. We talked about the specialty care, but the example I'm showing here on this slide is one in which there are basically two models of care being offered by this organization. One is an in-home intensive model of care focused on dually eligible individuals in end-of-life situations, you know, very complex, who frankly, the traditional in-clinic visit model is just frankly not appropriate for them, and more of a home-based model. And there's obviously a lot of energy around hospital at home or various other models of how do we bring services into the individual home. And those services are a mix of virtual as well as actual human beings of varying types visiting the individual in the home. The other is more your traditional Medicare clinic model. You know, obviously an ambulatory population, a more general population. Yes, there's some acuity. I mean, this is individuals over the age of 65, so there are some clinical issues, but much more manageable. I think the key thing here is under this structure is different TINs. Complete separation of the TINs between your health, between this in-home provider and the bricks and mortar alternative. Why is that important? Because when you get into whether it's the Medicare APM programs or even Medicare Advantage contracts, keeping those TINs separate, keeping them and allowing them to have their own approaches to value-based care and separate, in essence, negotiations around those populations, I think can lead us to a better general outcome in terms of what contracts you can get. We've had a couple of different organizations who combined those patients into a single TIN and lost money, particularly in the ACO REACH program. So I think that this is not a perfect scenario, but I think if you are going to really think about, and we always talk about this in value-based care, the need to segment the population, to think about them in different ways, I think you have to include in that the idea that the fundamental model of care for certain populations can and should be different than it is for other populations. I think a problem of fee-for-service, and the legacy of fee-for-service, honestly, is going to live with us for a generation. I can't remember who is it. I think you were saying turn it. It's like, you know, it's like turning a ship around into a giant ocean liner. Things that we were going to do today hopefully bear fruit, you know, a decade, 2 decades now into the future. One of the issues that we have to deal with is that almost any physician office you walk into is structured very much along the same lines. They are structured based on throughput efficiency. The patient experience is highly standardized, and it is not purpose-built for the truly medically complex, the polychronic type individuals. 4 minutes with a physician is not enough for that population. And so we have to start thinking about new models of care. That's, if I have a axe to grind, it's that value-based care has led to a lot of different contracts, but it hasn't fundamentally led to enough new models, new approaches to care. And where I think we fundamentally should be focusing that effort is really on this polychronic population. There's so much avoidable cost out there. There's so many better outcomes that we could get if we do that. And so that's why I'm an advocate for separate TINs, and with that, allow those separate TINs to pursue different clinical models. That said, there are economies of scale associated with the provision of healthcare services, and you want to still capture some of those efficiencies. You want to standardize care. And so in this model, what you have is multiple states. You have different TINs you have 2 TINs in each state, so you have 2 different models in each state. But ultimately, this MSO is supporting each of those organizations. You have a centralized entity that's supporting those provider groups in each of those individual states. So you're trying to still capture some economies of scale. And frankly, also, you will see, as one would expect, certain providers, certain markets will move faster, will achieve improvement quicker. You're going to want to capture those lessons learned, figure out what was the secret sauce, and then apply that in other areas. You also eventually will want to standardize this into a playbook. I've seen a few examples of this. The most prescient one I ever saw was Oak Street, which, has problems, but they literally had a Harvard Business School case study on literally how they designed the physical clinic, how they operated, who they hired, how they trained, all those things. I think that those are the kinds of things that as you evolve, if you really want to be a multi-state, if you really do want to achieve scale, you have to achieve that degree of standardization. And then lastly is just, what are some of the basic roles and types of contracts that these organizations would go into? The path to value for the home visiting program is a different value path to value than the bricks and mortar. And I think you just have to approach each of those different service lines, in essence, very differently. But I think ultimately a successful model is one in which the MSO is able to support all those. And then ultimately you get these playbooks written, you standardize certain processes, and as a result, you've created a platform that's ready for scale. And I think, back to the earlier argument, the other benefit of this, back to the legal rationale for doing this and why it's so important to get the legal structures also right, is that if you don't do this, you open yourself up to potential litigation, fines. You could have, some pretty significant, and because things like corporate practice of medicine, the laws vary by state. Some states are very strict. Other states are very lenient. But if you really want to grow and be able to go into other markets and do that successfully and quickly, you need the right platform.
And if you wouldn't mind, if I could make a couple of comments, can you go back to your prior slide?
Oops.
On the model and...
Okay.
So when you talk about scaling and you start talking about using 2 separate clinical entities in each state, and you're differentiating basically the way you want to contract for the different TINs or tax ID numbers that they're billed under. And there's part of this standardization is, and it's kind of what you were describing, you and I have talked about this in the past with Oak Street, you almost commoditize the model and you keep replicating it from state to state. But you got to deal with the differences in states. So you got differences in state law, you got differences in corporate practice of medicine. If this is private equity or some other entrepreneurial investor that's not a licensed professional, an MD, that's steering all of this, then you're more than likely going to need friendly physician, PAs or LLCs, and those are all corporate practice vehicles. And some states, like you said, are lenient, some are pretty strict. But the thing to think about, if you're going to do this and you really want to look ahead, the new value-based regulations I mentioned in an earlier session, they allow, if you're a physician in a group practice, you can be paid in direct relationship to your referrals of designated health services. That's unallowed in Stark, elsewhere. But you got to be contracting with a value-based enterprise, and you have to be the physicians receiving the payment have to be in a group practice. And so that opens some opportunities. And here, when you look at these models, if you're scaling from state to state, you need to, if you want to be forward thinking, it's kind of what you're talking about, the tipping point, that may come much faster with a new presidential administration. They put the right people in place. And if things move quickly and you're scaling and you find advantages because, health systems and other, facilities are negotiating value-based contracts with you, then you may want to be a group practice. And so you need to think ahead. And one of the components is you got to have, 75% of the providers be employed. And when you start going state by state, you might have them billing some of their services over here and billing some in another, friendly physician entity. And to do that, Stark Law does allow, if you got common law, under common law standards, the IRS standards, you can lease those doctors and have them be employees. Now, there's also some payroll tax implications, and there's techniques to do that. But if you're forward-looking, thinking about, do I want to preserve the group practice designation, and then if you've got the value-based enterprise like you've got there, or you're negotiating with the health system or somebody else, and I think John Carter mentioned earlier that the Stark regulations have an example, which would have been unheard of without these new regulations, is a health system paying every time the physician orders using a dual modality, because it's going to potentially detect things if they just use one diagnostic test. And if you're doing this dual modality test, and you're getting paid for every referral. And so those kind of things that may happen in the future, you got to be a group practice. So if you're scaling and moving and everything's moving fast, and that's part of the benefit of sort of commoditizing your approach in state by state. And then the other thing is, if you've got the value-based enterprise and the SIN there, you can start contracting with other providers. The conversations we had earlier, you can start negotiating and bringing it into providers. You don't have to own everything and buy everything. You may find strategic places, even with health systems. I mean, they may find a private equity platform in a health system. They want to come together. But if you've got a powerful ability to do that, then it lends itself to really being creative in the future. And I think you also mentioned a central MSO, but that point about leasing staff, you centralize the staff in the organization. You got one set of payroll functions. You got one set of of obligations to do that. If you're leasing physicians and making them common law employees, there's techniques to make them employees and deal with payroll tax consequences. But I think the final thing I say is there are some recent private letter rulings. If you roll up to a corporate entity, that could be a limited liability company that's a holding company parent, all these friendly physician entities might be able to file consolidated returns. And that that's a big savings right there in terms of your annual tax compliance. So those are, if you're building a model, you want to think ahead and be as forward thinking as possible.
Absolutely.
Well, that's a good starting point. And I apologize, but I was so busy trying to get y'all's introductions. Our title is Entrepreneurial Opportunities in Value-Based Care, New Models of Care. So you opened up with sort of what you would recommend as sort of a view of a scalable model. And now I'd like to maybe go to Alex and can you tell us about, in your experience, what drives value-based care and financial success, particularly in the compensation area?
Yeah, I'd be happy to. And let me.
It's the big button. There you go.
So Jason commented earlier about how segregating the tens, and if you get them all mixed together, you could get undesirable results in that. I think that the same thing is true in a practice setting, where the ideal setting is to do some patient segmentation, identify who your Medicare Advantage risk contract patients are, and try to set up a compensation model that is aligned towards that, versus one where you have a lot of fee-for-service type patients. The thing to be mindful of that is that physicians are not going to want to be forced to go into a certain compensation model. And so, because you've got physicians that have practiced for years, have a certain mindset of, I'm going to see 30 patients a day and I've got to bust it. The work RVU model for fee-for-service very much incentivizes that. And so trying to shift the incentives in that way, but being thoughtful about the makeup of the provider base that you're dealing with is going to be a very important dynamic, trying to get value-based care turned. On one of your earlier slides, you showed the HCP land top barrier to advancing value-based care was providers' willingness to take on risk. They got to get the incentives aligned in that. And what a key stat I wanted to share that I thought was insightful is a physician advocacy group. They've conducted a study, and now here they're showing that 78% of all physicians are employed. And so there's not very many in private practice any longer. That 78% breaks out to 55% of them are hospital health system employed. 23% is corporate employment. And that's where you can see some of the private equity roll-up areas, Optum, Kaiser, some of those types of organizations. But and we've seen movement on that bottom line coming out of the pandemic where there was investment and deals being made. Now, if you look, the bigger movement has been in the hospital employed space where physicians have turned to trying to shield themselves from revenue risk. And so trying to get them to jump straight into a value-based model, it takes some thoughtfulness because kind of like on the payer side, there's been on-ramps to have upside only and only take part in the upside. For the physician side, what is this new world, this new way of seeing patients and being incentivized? How are you going to mitigate some of that risk? And it's a challenge because a lot of the doctors are going to be in the hospital health system employed, which is driven by predominantly work RVU-based compensation models.
So are you seeing any differences in compensation and distribution models, Alex, and particularly trying to mirror maybe what private equity's doing out there?
Yeah, so we see a lot of organizations develop SINs and how they contemplate their distributions, and a problem with that in the health systems that oversee that is that it takes over a year to get the shared savings payment reconciled and figure out how much money is there to pay out. And so trying to get independents signed up for that and get them a value proposition and recognize some of that, but you have to wait over a year's time to see any of those monies has been problematic. And so we've seen some PE entities try to underwrite that risk and pay more timely payments, and have seen the health systems kind of follow suit in that, trying to pay out distributions based on where they can see their risk headed over the coming year, pay that out more on like a quarterly or biannually basis, so that they're not waiting until over a year later to get those distribution payments.
Okay. Lewis, part of the role of an entrepreneur is to expand the total addressable market for the business. And beyond just diving into programs with shared savings and capitation, what are some examples of a glide path into a value-based care involving specialties we don't always think of in this space?
Yeah, I think that's a great question. So for those types of specialties, they typically fall closer to the crawl end of the spectrum, of the crawl, walk, run spectrum. And so I thought a helpful way to think about opportunities for those types of specialties or even practices is to look at kind of the overlap in care domains between the different types of practices and settings of care. And so what this slide here shows is kind of good areas of opportunity for folks that are looking to make investments in value-based care and where that overlap exists. So you can see in the case of, for example, primary care and hospitals, there is oftentimes synergies associated with addressing unmet care needs For example, you've got patients that don't have a primary care provider assigned that show up at the hospital, or they do, but they have unmet kind of community needs, and so they benefit from addressing social determinants of health. In the case of looking at specialist and primary care overlap, there's ongoing management of chronic conditions. For hospitals and specialty care providers, there is opportunities for efficiency that exists after stabilization of the patient, moving then to the discharge and management of care after discharge. And then amongst all three, there is the ongoing management of transitions of care, particularly associated with high acute episodes. So when thinking about kind of the total addressable market, I think this gives a helpful framework, but it raises the question, if I'm going to invest in a model that's focused in these spaces, what is my opportunity for funding? How can I find a way to create a sustainable business that down the line is looking to take on risk from payers? And so what I think is very interesting is that Medicare has thought that through and implemented a number of different CPT codes within the Part B payment system to facilitate a lot of what I had just mentioned earlier. So if you take a look in the context of primary care and hospital care, I think a really interesting new opportunity for entrepreneurs is looking at the community health integration and principal illness navigation reimbursement that was added. What this is intended to do is cover the costs associated with care team staff that's focused on managing unmet needs in the case of community health integration, so connecting patients to places like food banks if there's food insecurity. In the case of principal illness navigation, the funding here is focused on care navigators that are kind of guiding patients through the healthcare system. So, you just found out that you need a colorectal cancer screening. Okay, where do I go to get that screening? I need a reminder as to when that screening is coming up. So there's revenue opportunities there that exist within those codes. What those codes are essentially a way to take the fee-for-service chassis, as everyone here has talked about, and implement a more capitated type model, because these codes reimburse on a per beneficiary per month basis. I'm not going to go through some of the other examples that are shown here, but the reason why I bring these up is because if you dig into the CPT codes and you're an investor, one of the things that stands out is that the gross margins associated with these services are actually quite good. If you take a look at the cost of a care navigator and compare the amount of time that they need to spend in order to bill for these codes and what Medicare reimburses, there's a reasonable gross margin. What has happened amongst a lot of organizations, though, is they fall apart from the gross margin to operating margin transition, because these are not high reimbursing codes and they require a significant amount of infrastructure to be able to fund. So that, though, seems to me to stand out as a recipe for outside investors, where you can really build platforms of scale, whether it's around efficiently utilizing staff. And I'll plug a company that I've worked with, Rely Health is a company that uses AI to really facilitate the reach of care navigators. So whether it's using technology, whether it's finding out processes that work best, I think there's a lot of opportunities for investors to ratchet down those operating costs and approach more of the gross margin opportunities that are associated with some of these codes.
If I could just add, we have had multiple clients who particularly very focused in that homebound, the high needs population, who, while they struggled to find past the value-based care, found a path in fee-for-service just to be able to basically, that all these new codes plus the more intensive model of care led to adequate revenue to more than cover their costs. Now, not huge margin business, but one of the challenges in value-based care is that if my model is primarily based around value-based care, and my assumption is that I need a value-based contract in order to be able to break even, how do I deal with the fact that, especially when I'm small, when I don't have a lot of patients, how do I survive until I get to scale? But if you can make money, positive margin in fee-for-service, as you grow your patients, then look, and especially when you get enough patients with individual insurers on the MA side, or big enough to do, MSSP or REACH, you can then flip into those models as well. But I think that is also one of the scaling challenges entrepreneurs have, is how do I, avoid the losses? And I think that's the other big difference in the investor environment today that it was in 2020 or 2020, when people had a high tolerance for losses. It was just kind of like, as long as you had exponential growth and people saw the top line and they believed you had an eventual path, they were willing to finance those losses. Fast forwarded today, and investors just do not have a stomach for loss-making enterprises. So you have to, if you're going to do this, you have to figure out a way to do it at least break even. And I think these codes that you're highlighting creates that opportunity.
Now that's a good point. I know as we sort of evolve, healthcare in the last couple of decades, particularly when you see the advent of a lot of private equity and private capital, it's been to just sort of bolster the revenues as quickly as possible, and so it's interesting what experiences y'all may have in terms of how much you see those strategies shifting, like you say, to have something more sustainable and long-term, because some of these revenues are being ratcheted back. I mean, ancillaries and things like that. But how much of a focus do y'all see in y'all's businesses with the private equity and other entrepreneurs out there really extending and looking ahead and trying to understand what they need to do to have those sustainable margins and those sustainable revenues?
I could start. I would say is obviously the rise of interest rates and inflation and just the cooling of deal making. People are sitting on assets longer than they would frankly have liked to have looked. Also, I think some of the the smell is off the rose, so to speak, with health tech. There's a lot of interest, a lot of capital being plugged into companies, in some cases, with business models that were less than ideal. But back when capital was flowing, very quickly and valuations were crazy high, there was just, a lot of investment in some of these sort of new models of care companies. And I think some of, investors are asking tougher questions. And as I said, focus much more on, are you a break-even company? How quickly do you get to break even? But I do think it's also is that I get the feeling that investors are becoming a little more realistic in terms of the amount of time it will take to get that double, triple value on the asset after purchase. That it takes time to build, as you were saying, to build the infrastructure, to achieve some of the synergies, to achieve the scale that's necessary to do it. And so I believe they're getting more realistic. I feared a little bit, honestly, that when deal making kind of stopped, I worried whether or not, while there's still all that dry powder sitting out there on these PE balance sheets, that when things started moving again, that interest would move away from healthcare, move to other sectors. I have not seen that. I still think there's a lot of interest in new models of care. People see the inefficiencies, they see opportunities. They also believe at the end of the day that healthcare companies are a little more counter-cyclical in the sense that they have some protection against economic downturn that other sectors where they might invest their capital don't. So I remain pretty bullish on it. I do fear, the last thing I'll say on it is I fear a little bit is, I mentioned during my talk was just there's been increased scrutiny on the role of healthcare. We've had some, I would say, some pretty bad examples. I think that certain types of PE behavior are going to be watched very closely. The typical roll-up, generate market share, increase unit prices, that sort of playbook, I think is more problematic. I think you're going to have to offer more than just market share, offer more than just driving up fee-for-service prices as your value proposition. We deal with enough investors who I think share that interest. So I remain bullish on the sector.
I would say too that a lot of these private equity firms have acquired practices that, though they don't know it, might make for great candidates in value-based partnerships with hospitals. One example that I've worked on that really comes to mind is a podiatry practice that was affiliated with a larger orthopedic group that operated in a community that had a significant proportion of patients that had diabetes and unmanaged primary care. And so these patients were in severe need of podiatrists to manage diabetic foot ulcers and avoid really some really bad adverse outcomes. And what they identified was an opportunity with a health system to develop a value-based arrangement where the podiatrists were frustrated because they would have to go to the hospital to provide services that take them away from the practice. They were asking the hospital for call stipends. Hospital didn't want to pay call stipends because it's just a cost of doing business. And so they kind of flipped the script and looked at it as how do we create a value-based partnership that's a win-win for the both of us, and formed a value-based enterprise that was really focused on these folks that had diabetic foot ulcers, managing those patients. Hospital had the benefit of gaining better access by putting dollars on the table, but those dollars were paid in an at-risk fashion so that the private podiatry practice benefited when they were delivering better outcomes. Patients were seen more quickly. They made it back to their primary care providers for diabetes management and so on. So I think investors and healthcare should take a look at the assets they have and find ways to develop value-based partnerships that don't necessarily involve having to take on payer risk.
You know, one thing that comes to mind just hearing y'all talk, and I know from over time when, you know, health systems first started acquiring medical practices and then private equity started coming into the space. And in the old days, there were the roll-ups if they weren't blow-ups, and then, you know, the ones that are, you know, left. But you know, the one sort of dilemma that I always saw was, you know, physicians and independent medical practices, and yes, there's less today, but, you know, they typically bonused out all the cash. I mean, their compensation was basically everything they could earn before the end of the year. And so when you know, acquirer, whether it's a health system or whether it's a, you know, private equity comes in, they have to ratchet up those revenues and grow those revenues in a way if they're going to pay them the same dollars. And sometimes they want to pay them more dollars. Or one model is you pay them less and they get cashed out. And so, you know, the people that weren't getting the equity holders, they're not so happy about that. But I think that's sort of the classic fee for service, sort of eat what you kill, you take it all out the door. But do y'all see opportunities, or are you seeing in your own practices where the value-based type population health and keeping people well and all that sort of stuff, is that delivering revenue streams yet that sort of give people those marginal revenues to grow and sustain and keep those providers happy?
If I had to pick a class of provider that I am most bullish on, like if I was going to investing my own money in a particular class, like just, I like the physician-led ACO, particularly the primary care focused with probably some ancillary, and we obviously had one really good example of that right down the road here. And the reason I'm so bullish on that type of organization and why I actually think, back to your chart, I think we could see that trend line reverse course. I could see physicians breaking away from employed status, at least employed in the traditional sort of hospital or Optum insurance company type status, and wanting to potentially get an equity share in an ACO, a for-profit ACO, and bring in outside capital to finance the operations and achieve some of the efficiency and work through some of the operational issues to maximize the most of these codes. Because what makes me so ambitious or so optimistic about this group is that is two things. One, compared to the hospital outpatient environment, the services they provide are cheap, much cheaper. The rates of reimbursement are much less. The regulatory environment in which they operate is much less, so that brings down their cost structure as well. And the second is for those groups, they talk about eat what you kill, like all that shared savings, it's coming out of someone else's hide. It's coming out of particularly the hospital's hide. Now, I agree you could create structures and win-wins and look for it, but I think a lot of what value-based care has the potential, and I think we are already seeing it in certain examples. It is a huge power shift in American healthcare. Hospitals and insurance companies have been at the top of the food chain. They have told everyone else what to do. They have disrespected community-based physicians for generations. Those were always seen as second-class citizens. The hospital executives and the insurance company executives always at the top, and these independent physicians at the bottom. Value-based care, and seriously, primary care, community-based physicians. They were the lowest paid of almost any kind of physician you can find in the United States. Now, all of a sudden, they organize themselves into groups. They take on the risk. They go all the way to full capitation, right? They hire a TPA. Hospitals and other providers are now downstream from them. They're getting that full top-line revenue capitation. All of a sudden, these organizations are multi-billion-dollar enterprises. They start approaching the size of the hospital in terms of top-line revenue. They're capturing all that savings. They're the ones who control the patients and the services and the population. And I think it's a totally underappreciated aspect of where this all could go, is that we could end up in 5-10 years from now seeing a totally different power dynamic in American healthcare after all these years of these institutions and large insurance companies being the dominant force. Could this mean the rise again of the American physician as a group of individuals empowered to really meet the needs of populations? That makes me optimistic.
And it really goes back to even the title of this panel. But when you bring physician entrepreneurs or physicians that are pairing with entrepreneurs, then they really can empower it, because they're the ones that are starting and directing everything. So,
and that's where I think back to this. I think the work you do is like as important as anything else, because that's the ultimate. It's like the physicians, the ones with the pen, computer, keyboard, who control 80% of the healthcare costs. How do we incentivize them? And as long as they're getting paid RVUs, as long as they are incented to do that, part of the reason I think we have seen less new models of care is because when the rubber really hits the road, where physicians are determined how much they paid and how they organize their office, it's still throughput efficiency is what is king. And if we can change those reimbursement models to begin to incentivize, and one way to do that is give them a share of equity, ownership in that broader entity, so that they have a real skin in the game and the opportunity that when they retire, they can cash out of something that's bigger, more valuable and such. But that's why I think that's why what you're doing to try to transform physician reimbursement is so key.
And I think that is on the road ahead. We've been talking about the shift from volume to value for decades now, and it hasn't moved so much. I think one of the major reasons is because the demographics of the provider workforce and the mindset that they may have that is fee for service.
Yeah.
And no matter what you try to do, they're not going to change their ways. This is how I practice medicine. This is what I do, and that's what it is. But now we see that demographic starting to retire more and more, and it's being replaced with a younger generation that grew up with EHRs and all these types of analytic insights and these types of things. And so I think that we're on the verge of seeing the physician labor workforce a lot more receptive to these types of concepts, especially as the idea of ownership comes into play and things of that nature. And that could really ignite interest in that regard.
Yeah. Optum can't offer you meaningful equity in Optum.
now those are interesting comments and observations. I get so, Jason. I think if I hear you say, and you're predicting this could be a shift in sort of who's in charge back to the physician providers. And when I hear you say that, I kind of think in terms of what may not be necessarily the small groups, but maybe like accounting firms and law firms have created, grown to be, leveraged in size. You may, particularly around all these things we're talking about with value-based enterprises and SINs and super SINs, they could really enhance and leverage a lot with the right entrepreneurial focus going in there to create these things.
And to go back to both Jason and Ed, your point about setting the organization up correctly, there's a lot of opportunity for, if you're a physician-led organization and you might want to develop a partnership with entities on an independent basis before you bring them in-house, the value-based enterprise structure allows for you to do things like care coordination, like share in some of the scalable platforms that you've built, technological platforms, people platforms, to enhance value-based care. And so it really is, a kind of a force multiplier in the realm of getting practices to work with practices together in partnership models that in the past the regulatory framework wouldn't allow.
And Jason, I know you and I have talked before about this, but haven't you seen that like in the ACO space, that being sort of a feeder for picking out the groups that they can actually do better with by bringing them into?
Yeah, we've got a client that I think at its core you'd call it a private equity fund, but it was purposely built and generated. I think their first fund was like $1 billion, and they went out and started acquiring physician groups. Started in New York City, but now have expanded across the country. They got about 2 million attributed lives, but they're sort of across the board in terms of different payers. Different payer mixes, different focuses. They got everything from pediatrics to a lot of obviously Medicare, some Medicaid as well, and they're building what they believe is potentially a really sort of state-of-the-art MSO that's in essence designed to support all those different organizations, and one that's flexible enough to support those different provider groups, those different assets in different ways. Some of the assets they buy have a lot of in-house resources, and they don't want to like throw that out. And if it works, keep it. But then there's others that are, entirely creatures of fee-for-service. They may have a really good fee-for-service contract or two, but it's going to take a slower. They're looking at the APMs in a very sophisticated way. Sort of once again, like what's the right TIN for the right APM program with Medicare, and so but it's they're building a lot of this the support, the MSO and such from scratch, but I do think that is ultimately an interesting approach.
So another area I wanted to see if y'all had any thoughts on it when you talk about entrepreneurs and new models of care. But one of the things we hear a lot about today are social determinants of health, and it's not as exciting as ancillary revenues or scaling more providers. But I guess the piece that I've heard, and there's a lot of focus on that, and I know the Medicare program is looking at that in a lot of ways, but it's almost like you can do so much clinically to reduce costs and improve quality, but you have all these social determinant factors out there, and there's different estimates of the range of spend, the total healthcare spend. But if you make adjustments on that side, you're sort of hitting the other side of the coin. So if you're the entrepreneur in here trying to maximize your returns, and you're trying to optimize the clinical side, what do y'all see people do you see that yet? Any significance with? I know the government's leaning in that direction, but trying to optimize to the extent you can with social determinants and markets where it makes sense to sort of leverage your returns.
Well,
Go ahead.
I was just going to say, I think that the bigger that the revenue opportunity becomes, the more meaningful and attractive the value-based enterprise becomes. And I think that value-based enterprise is going to start deploying other strategies of trying to reach out to patients in the area and get them to do the health access things that they may otherwise not do. And so I don't think we've seen a lot of it yet because there hasn't been a lot of financial incentive. But as that furthers, I think we'll see more and more of those strategies deployed, just getting them to the doctor and doing things that otherwise are not being done.
You've got now multiple states through the Medicaid programs have gotten CMS approval for funding for what are called health-related social need services, which in essence are things that Medicaid traditionally went to pay for, but now funding is available to pay for some of these services, like nutritional support, including healthy groceries or medically tailored meals, to non-healthcare related transportation services, to housing. In fact, in New York, up to 6 months worth of rental subsidy for individuals, particularly like a post-hospital discharge that have no safe place to discharge. So I think it's those things are being done, rolled out in a very fee-for-service kind of a way, meaning it's a service, there's a billing code, there's a rate, you provide that service. CMS's argument is much like fee-for-service. We were talking about the new Medicare codes, the relatively new Medicare codes. people begin to figure out how to do a business around providing those services within the confines of the rates that are being paid for it. And eventually you build an infrastructure, you build a service delivery system for these services. The good news for, like in New York's case, for value-based contractors for the Medicaid population, and I mentioned earlier, there's a lot of value-based contracting, is that for at least for the initial first couple of years, it's like free money. Those dollars flow outside of capitation rates that providers may be in or whatever. It's a separate funding source that, so at least initially, they get to benefit from it in the sense if they just figure out how to get their people to the services through closed loop and other things, you can use that to basically help you reduce costs. One thing I would say, and I'm a huge believer, former Medicaid director in 2 states, that we need to address social determinants of health. However, I think we also have to be realistic about these different strategies. There now have been multiple studies that have looked at various interfaces. One of them, randomized control trial, that looked at Geisinger's very sophisticated, I would call it the Cadillac approach to healthy food for diabetics, and focus on a control group versus those who received food. It was like spread across different geographies. And the randomized control trial found no discernible difference in terms of change in hemoglobin A1C between those two groups, those who got the food and those who didn't. This is a very complicated issue, social care needs of individuals. We have a lot more to learn to figure out how to do it. Partly, I think our issue is the chasing the tail problem. We're always looking back at who cost us a lot of money last year. We are not as good at predicting risk as we should be. And I think once we get better at predicting risk, we'll get better at directing strategies towards them. But there is money flowing into SDOH that hasn't been, in New York's case, I think it's like $3 billion. So that is going to generate people trying things, which I think is good. We just have to be realistic. It's not, a slam dunk panacea for all of our general healthcare challenges.
Yeah, one of the things I personally haven't seen, but I'd be curious to see is along those same lines within those types of social determinants of health programs, organizations taking advantage of the anti-kickback safe harbor around providing supports to patients, and perhaps that being a means where in the past, I needed to pay a copay, and that was a deterrent to acquiring an item's service, but being able to provide that to beneficiaries, especially those with unmet needs, and seeing if that moves the needle to the point of an earlier question about how do we get patients engaged in taking care of their health.
Absolutely.
Now, those are all good points, and I've had a couple of conversations with clients, but it just seems like, too, with the value-based, if you really get serious and you're contracting and you've got a vehicle that's contracting and it's functioning as a SIN and you're building together networks, and if you're scaling, you're obviously going to be going into different markets, and you may hit places where, like New York City or other places where you're going to have more pockets with higher needs. It just seems, what I hear today, that there's a lot of people that rely upon volunteers, they get other agencies, local agencies, and food banks and others, to help. But at some point, why not just negotiate with payers for something to fund the social determinants? In other words, to try to get those dollars in here to fuel it, to have, if there's stuff that is that working, then you have something effective. Then you got a sustainable stream to keep it going.
I would love to be optimistic that the payers are going to agree to fund it without the government sort of driving it. I just think, especially right now with Medicare Advantage, we talked about V28. There's a lot of factors going on right now that are squeezing on the MA side and also on Medicaid side. I just don't see it also on the commercial side, them funding it. I think it's going to have to be the government that's going to have to come. The one thing I want to say, though, about Entrepreneurial is that, and I know that we're going to have to wrap this up, is technology. I know the next panel is on AI. Mm-hmm. I mean, one of the things that makes me most excited about entrepreneur-based and private equity-backed healthcare providers is we desperately need to figure out how to deploy these new technologies into the clinical setting, not just into the back office, not just into data analytics, but into the actual clinical setting. Why? Because we do not have enough clinicians. And it was mentioned earlier, we are running out of clinicians. We are not replacing clinicians as fast as we are losing them. There's no way for us to hire our way out of that problem. It is a global problem, not just an American problem. And so I think at the end of the day, we have to figure out how to put technology into the direct care provision space. And I have more optimism that an entrepreneur model of care, if that's what we call it, are better positioned to push the envelope on that. And I think ultimately, that's why part of what I'm hoping for is we will see new models of care that will be really pushing the edge of what we can do in clinical care with artificial intelligence.
If we have any questions, we've got some microphones. We got a little bit of time. Does anybody in the audience have questions? But if so, raise your hand and we'll get a microphone to you. Anybody? We got one out here. Lana.
Hold on for the mic, sir.
I don't actually want to be a Debbie Downer, but looking for the leadership to put groups together. Physicians like their autonomy. They don't like to be subordinate. But it's difficult to get even different specialties, large groups in a given area together to drive some kind of process like this. So I'm not sure how you overcome that. The second part is the youngsters coming out want to work 9 to 5. They may actually be part of the solution because they don't have the ego-driven, got to be in front, got to make it all good. But it's still going to take somebody that can pull the string to get everybody heading in the same direction.
I know a couple, anybody have comments about the work-life balance?
I think it's real. I mean, I think healthcare worker burnout is real. I think it's getting worse, and we shouldn't be surprised that the more recent graduates are 100% focused on a more reasonable life balance and are not going to accept. I think it's also back to technology and new models of care. Providers that are able to offer the work-life balance that these younger providers are looking for are going to be the ones who are best positioned in the marketplace to, hire those people. I just think that's, I think that's what people are looking for. That's what people want. But in order for us to do that, we have to figure out how to use technology better. And we got new models of care, new approaches. This idea of the classic, everybody has a PCP, everybody goes to see that PCP at least once a year, and it's a face-to-face visit. I just think that I don't think that model ever really existed in the United States. Existed much more so in other countries. NHS England's a good example. But we relied basically on the fact we had a huge uninsured population in this country who didn't have easy access to primary care services unless it was entirely out of their pocket. And the second thing was that we just had a lot of people who just weren't forced to use it, used urgent care or whatever else, and weren't going to appointments that they should have. And that left enough capacity in the system for the rest of us who decided to use it appropriately. But if we ever actually got all Americans to try to get in that model, there's no way we could possibly staff it. So I just think, back to this, is automation in healthcare isn't like an option, it's an essential thing. Otherwise, the quality of care, access, the waits everybody has in this country and every other one is just going to get worse. And it makes a lot of people uncomfortable to think about getting care from a machine, but that is exactly where this has to go. I don't think there's any ifs, ands, or buts about it.
If we can, we're out of time, but I just want to answer the other question you asked, Lanny, and that is how do you get providers? They don't want to be in big organizations, and that's part of the topic we've been talking about all day. These clinical integration networks that aggregate practices, you don't have to be super large, but you can still aggregate with entrepreneurs driving that SIN, value-based enterprise. That is another path to being independent or coming back and being independent if you don't like where you are. And you kind of take control, like you said, of your own fate. And so that's one model. But we're out of time. If y'all have more questions, obviously our panelists will be here at the break. But if y'all would, give us our panel a big hand. Thank y'all very much.